All right, so we're going to talk about two other conditions called potentially lethal EKGs. We're going to talk about hyperkalemia and Brugada syndrome. I chose these two topics because certainly the hyperkalemia part you guys come across quite often. It is a very common electrolyte abnormality that we see in the emergency department. So it is very important for us to understand the limitations of EKG in assessing at least this condition. Certainly, at the end of the day, you get your blood work and you get your number, but certainly EKG can clue you in if you have severe hyperkalemia. So with hyperkalemia, to begin with, we have three grades. We have mild, moderate, severe. Mild hyperkalemia is 5.5 to 6.5. Moderate is 6.5 to 7.5, and severe is greater than 7.5. EKG is not a good tool in diagnosing mild hyperkalemia. The EKG changes associated with hyperkalemia typically start at a level of about 6.8. So you can see that with mild hyperkalemia, 5.5 to 6.5, you're not going to see much of any changes, so not that helpful. Overall, also, you'll have many textbooks, many articles that have written about EKGs, and what you've learned in your medical education, that there are progression of EKG changes that you'll see that are associated with hyperkalemia as hyperkalemia gets worse. And this progression, this stepwise progression that we'll talk about, I want you to know that in real life, you may not see it that way. You may see one presentation that typically you may see at the end of it, and you may not have the initial typical presentation. So what you'll see initially with hyperkalemia, you'll see these tall peaked T waves. And that's the typical pattern that you'll see. You'll see these tall peaked T waves, and we'll talk about them in a little bit. So here you have a patient that comes in, complains of polyuria, and you can see the T waves. The T waves are really tall and peaked. The classic teaching with hyperkalemia, as it progresses, you have your tall peak T waves. Then what you'll see is that your P waves start losing their height. As P waves start losing their height, they'll start to disappear. The QRS starts to widen. And then you get what's called a sine wave, where it's a wide QRS and a wide T wave. Wide QRS with a wide T wave, you have your sine wave, which is the ultimate end result of severe hypokalemia. This is the typical progression, but I want you to understand that you may not have this classic progression all the time. Hyperkalemia can present with multiple types of rhythm disturbances. You may have, for example, accelerated junctional rhythm. You may have idioventricular rhythm or accelerated idioventricular rhythm. And all of those can be just manifestations of your hyperkalemia. And you may not have your peak T waves. So although we talk about these things, you need to keep in mind that many rhythm disturbances can present as a manifestation of hyperkalemia. So whenever you see junctional rhythms or accelerated junctional rhythms, where you don't have a P wave, you have a narrow QRS, that could be a manifestation of hyperkalemia, because with hyperkalemia, you remember, you lose your P wave. Or you may have idioventricular rhythm, where you have no P wave and a wide QRS, and that could be a manifestation of the hyperkalemia. And you may not have peak T waves. So that as an introduction, but we still, whenever we see peak T waves, we are always concerned about hyperkalemia. So before we get to the peak T wave, we have to learn what's a normal T wave. Remember, my philosophy with understanding EKGs rests on you knowing what is normal. The rest is actually fairly easy. As long as you understand that's not normal, the rest is fairly straightforward, because even if you don't know what's going on, you know it's not normal, you're going to seek help. So here, by the way, the K on this patient is 8.1, pretty severe. And you can see that at severe state, even at 8.1, you can have your peak T waves. You don't have much of a wide QRS. You do not have loss of P wave. And you can see you have severe hyperkalemia. All right, so let's talk about a normal T wave. A normal T wave has a slow uptake and a fast drop. From the peak of the T wave, if we draw a line down and we divide the T wave in half, the first portion will have a lot more area compared to the second portion. So if you divide the T wave from the peak of it in half, you have a lot of area under the curve, the first portion, and you have a small area under the other one. It's a slow uptake and a fast drop. A normal T wave should have that contour. Anytime you do not have that contour, something isn't right. Doesn't mean devastating outcome, but it's just not normal. So the two conditions we're going to think about whenever that is the case is, one is hyperkalemia. With hyperkalemia, you have a fast uptake and a fast drop. If we divide the T wave in half, the area under the curve, the both sides will be fairly equal. The base of the T wave, look at the base of the T wave, the one that says hyperkalemic T wave. The base is fairly narrow. You can see it's a very narrow space. So fast uptake, fast drop has a narrow base. There's other condition where you may see peak T waves, and it's not that commonly seen, but you will encounter it in your clinical practice. And it's called the hyperacute T waves of early myocardial infarction. This is a phenomenon that I've seen on multiple occasions in practice. This is a phenomenon that you will encounter, and most often it is missed because you don't have your classic ST segment elevation, you don't have your reciprocal changes. It's in very acute state that you'll see that, and this progresses to ST elevations and reciprocal changes as time goes on. So the hyperacute T waves they're peaked, but they maintain these asymmetric slow uptake and a fast drop. And the base is very wide. The base is wide. So compare hyperkalemic T wave to hyperacute T waves. One is the morphology. One is fast up, fast down. The other one is slow up and fast down. And the base is very narrow with hyperkalemic T wave, as opposed to hyperacute T waves is fairly wide. There's no number. There's no specific definition of what's wide, what's not. You kind of have to see it, and you can kind of get the width. You see how different they are, but there's no specific criteria. So this is the first patient treated for hyperkalemia. You can see how things have normalized. You can see how STs have come back to their normal shapes. I'm sorry, the T waves have come to their normal shape. So we talked about all of these. It's in your syllabus. We talked about the peak. There are various criteria as far as what the height is supposed to be. I won't be so much concerned about that. I put it in there for you guys, but don't worry about so much. What I want you to learn is what's normal. From this session, this lecture, I want you to learn what's a normal T wave. Fast, slow uptake, fast drop. Slow uptake, fast drop. If we divide it in half, the area under the curves will not be equal. As I said, hyperkalemia, as things change, you end up losing your P wave, you end up getting wide QRSs, and you're getting your sine wave. Any altered conduction abnormalities you'll see, there's nothing specific. Not a reliable test for mild hyperkalemia. As I mentioned, the EKG changes start typically around 6.8. So if you have any EKG changes, you should already know that you probably are dealing with moderate hyperkalemia. All right, is this EKG hyperkalemia or not? This is a 50-year-old diabetic male with chest pain. Are the T's peaked? There kind of are. Okay. So is this hyperkalemia or not? So typically with hyperkalemia, the peaked T waves are fairly diffuse. They don't follow a specific arterial pattern. The peaked T waves of hyperkalemia are fairly symmetrical. Is V1 or V3 symmetrical? No, it's not. What's the base like? Wide or narrow? Fairly wide. So this is a great example of acute anterior myocardial infarction that needs to be dealt with immediately. This is an acute anterior myocardial infarction. So how could we have figured this out? Some basic rules. The morphology is the same as a normal T wave. The base is really wide. It's not diffuse. So this is not hyperkalemia. Look at the base. Really wide. If you divide it in half, slow uptake, fast drop. This is a 74-year-old female with a history of renal failure, presents with altered level of consciousness. This patient has atrial and ventricular pacing. So the first lines are the atrial, the taller lines are ventricular pacing. One of the things that you'll see with atrial and ventricular pacing, you get a wide QRS. But this is one that you should just kind of know. Again, this is just pattern recognition, that this is quite wide. This is wider than it's supposed to be. And this is something that you just basically need to kind of know. There's no specific rule to it. This doesn't look right. Certainly the lines don't look right. That's clearly, we understand that. These are your pacing. But the QRSs that follows those straight lines are fairly wide. So this is very, very concerning. And this is your sinusoidal waves. So you can see you have wide QRSs followed that wide T wave, followed by wide QRSs followed by T wave. And here the K was 7.8. Now think about this. This is a patient with a potassium of 7.8, has a sine wave already. Remember the first patient? What was the K on the first one? It was 8.1. And that patient had basically only peaked T waves. So this is a great example of every person responds differently to the hyperkalemia. You have a patient that will not have such a response to a K of 7.8. You have another one which will handle 8.1. So everybody handles it very differently. There's no specific rule to it. And you're going to come across this many times in your clinical practice. This patient was given ample of calcium. You can see that already the QRS is starting to narrow. And this is treatment afterwards. And you can see how the QRS has narrowed. Compare the last EKG, the QRS, to the first one. You can see how it is. The QRSs should be that much of a narrowness as opposed to how wide it was in the first one. All right. Next case is Brugada syndrome. This is a 32-year-old male with near-syncope. This is an important diagnosis for you to figure out on EKG because that's the only way you're going to figure it out because these patients die of sudden cardiac death. It is estimated that about 40% of sudden cardiac deaths are basically due to ventricular fibrillation due to possibly Brugada. It's basically a mutation in the sodium channels, and you get basically conduction abnormality. Typically, there's a family history of this, and typically patients present with a history of syncope. There's no good way of teaching you this phenomenon other than saying what you need to really look for and basically memorize it in a way. What we really care for is this pattern in V1 and V2. It has this basically RSR prime pattern, like a right bundle branch block pattern. You have a uptake and then downward and uptake, and has this basically very saddle cone shaped ST that comes down very quickly and fuses with an inverted T wave. The pattern that you should really recognize is how V1 and V2 looks like. You have this very fast downslope. It's a very steep, fast downslope that fuses in an inverted T wave. This is different than if you have a right bundle branch block with a horizontal ST segment and an upright T wave. This is very different than if you have a QRS that ends with a horizontal ST segment and a inverted T wave. They're quite different. So the phenomenon, the morphology that we're looking for is a very steep ST segment that fuses into an inverted T wave. You see it in V1 and V2. There are many different types of morphologies with Brugada, but this is the one that really you need to learn about. And this is the one that you'll commonly see. This is the one that you should just kind of have it to your memory. You have this very fast downward slope with T wave inversions. One of the pitfalls in assessing Brugada syndrome is that these EKG changes can be transient. So they may not always be present. So you may have a patient who has this EKG, and you may get an EKG on them later on, and that may disappear. Or they may have had an EKG before that was normal, and they come to you and they have it now. That is not such an unheard phenomenon. So this is as a result, I commonly recommend in patients, especially with syncope, repeat EKGs. You will be surprised what you will find at times. And one of them may be the Brugada that you may show. So the Brugada phenomenon of V1 and V2 may disappear and come back. So don't take it as you have basically an artifact or something like that. I have encountered this in my own clinical practice, and something that's described certainly in the literature. So I want you to memorize, kind of look at this. This is another one where I say for all the EKGs that you look, it's repetition, getting yourself familiar, recognizing patterns. So this pattern is extremely concerning, obviously needs to be further investigated. So we're looking for this. Basically, after the QRS, you have a downward ST segment, very fast downward, and it fuses with an inverted T wave. We talked about all this stuff. It accounts for about 40 to 6% of all cases of idiopathic ventricular fibrillation. As I mentioned, it's a mutation in the cardiac sodium channel gene, and the morphology is what you see. It is very different. Oftentimes it gets confused with right bundle branch block. However, the difference is that you have a nice ST segment with right bundle branch blocks. Then it follows with either upward T wave or downward T wave. With Brugada syndrome, you do not have a nice ST segment. It just basically goes down and fuses into a T wave. All right, so take-home points. Hyperkalemic T wave. Remember your hyperkalemic T waves. They're tall, symmetrical, with a narrow base. Your hyperacute T waves are asymmetrical, have a wide base. Anytime you have a T wave that does not follow the correct morphology, and what's a normal morphology? It's a fast uptake, slow uptake, and a fast drop. A normal T wave has a slow uptake and a fast drop. Every time that's not the case, I want you to think of two conditions. One of them is the hyperkalemia. The other one, are you dealing with hyperacute T waves? How do we tell the difference? Hyperkalemic T waves are somewhat diffuse. They have a symmetrical uptake and downward, and the base is narrow. Hyperacute T waves, they follow a specific region. They'll be in the inferior leads, they'll be in anterior leads, they'll have an asymmetrical uptake and downward, and they have a wide base. We talked about Brugada syndrome. I want you to memorize how it looks. It has usually see it in V1 and V2. V2, it has an ST segment that basically fasts downward and it fuses into a T wave that's inverted. It could be transient. I always recommend, my practice is always get one or two, get more than two, at least 2 EKGs. You're looking for these changes. And don't consider it an artifact if you see it, because oftentimes it's viewed that, oh, we have an artifact, this is not right, and actually that's when it shows it. All right, I think we're done with that one. And I'm just gonna follow into the other lecture, which is the unknown EKGs. With the unknown EKGs, I chose three conditions, and we'll go through them. It's kind of a review of what we've talked about, and so it will be kind of cool. So this is an 83-year-old male that presented with weakness. So we look at the EKG, and the first thing that comes to you, and it looks kind of unusual, are those weird-looking T waves in V4, V5, and V6. It's an 83-year-old male with weakness. Who knows what could be? Certainly the differential is fairly broad. And the EKG, other than those T waves, doesn't show much of anything else. Kind of bradycardic maybe. Really, not much. Well, then you get a call from the laboratory for a critical value. Isn't that so cool? Like, what could it be? I'm expecting maybe troponin or something. Well, guess what? Potassium is 8. We're like, what? 8? Where is my tall peak T waves? Well, guess what? You've learned about that already, that you don't have to always have it. Now, this is a very cool EKG, and I included this here because this EKG has something that what I teach, that you don't have to have all these phenomena in successions. So remember, the normal succession is you have tall peak T wave, the height of the P wave slows down, diminishes to a point that you lose your P wave, then your QRS widens, then you have your sine wave, basically. That's the typical teaching with hyperkalemia. Well, in this case, we don't have tall peak T wave, but where's our P wave? Do we have a P wave in there? Well, this is the stage where your P wave is the only manifestation of your hyperkalemia and when it's lost. Actually, if you look very, 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 very closely, right before QRS, you'll see a very small deflection that is consistent with every beat prior to every QRS. And there is the P wave. There is a very small P wave that's basically, it's almost gone, but it has still maintained some height. If you look very closely before every QRS, you'll see a very small P wave. And this is a great example of how hyperkalemia can present with many different types of abnormalities. And this whole classic teaching of you need to see this and that after each other, it's really, in real life, it doesn't really work like that. So we talked about all of these. All right, this is a 25-year-old male that presents with pleuritic chest pain. I talked about this earlier. Whenever you see EKGs with diffuse ST elevations, meaning ST elevations almost everywhere, we think about pericarditis. Patients with pericarditis complain of this pleuritic chest pain that oftentimes radiates to the trapezius ridge. That's a very common complaint with patients with pericarditis. They don't complain of pain going straight to the back, they complain of pain going to their trapezius ridge. Like I said, it's a pleuritic chest pain, and we commonly encounter it in our clinical practice. It's very difficult sometimes to diagnose based on EKGs because usually you see pericarditis in young individuals, and one of the conditions that it can be confused with is basically what's called the early repolarization phenomenon that you'll see on EKGs, where you get this ST segment elevation that are considered to be not really life-threatening. They have some implications down the line, but it's not considered immediate life-threatening. So we see many EKGs that we call it, well, it's a normal early repo. The ST segment elevations that you see is a normal early repo. So the problem is that whenever you see patients with pericarditis, that can be confused with early repo. So how do we tell when we have a patient who has diffuse ST elevation? Is that pericarditis or is that early repo? With early repolarization, typically you see ST elevations in precordial leads, but they can also be associated with inferior leads as well. So you may get diffuse ST elevation. Early repolarization can also cause PR segment depression. So you may see PR segment depressions. All of these things that I just said can be seen with pericarditis as well. So how do we tell the difference? The way you tell the difference is you're going to look at lead V6. So we specifically look at lead V6. So we have a patient that comes in with history that is compatible with pericarditis. Certainly in patients who have no chest pain and no concerns for it, that's not an issue. And you want to figure out if they have pericarditis or not. You get an EKG, you get diffuse ST segment elevations. The next thing that you're going to look is lead V6. In lead V6, we're going to look for some changes. Now, before I get to that, as I mentioned, you get PR segment depressions with pericarditis, and you have your ST segment elevations. The PR segment elevation over time goes away, and the ST segment elevation remains. So a lot of times, what you're going to see in clinical practice, most likely, is people coming with just diffuse ST segment elevation, and PR segment depression may not be there. The ST segment elevations are not more than what? 5 millimeters. They're not more than 5 millimeters. They're always concave. They're concave. They're never convex. And you have no reciprocal changes. The only place that you have ST depression is in lead AVR. AVR is the only place that you have ST depressions in pericarditis. Everywhere else, it should basically be up. You cannot have ST depressions inferiorly. If you have ST depressions inferiorly, you're not dealing with pericarditis. You cannot have ST depression in lead AVL. If you have that, you're not dealing with pericarditis. So the ST segment associated with pericarditis, it's not more than 5 millimeters, it's concave, and there are no reciprocal changes with the exception of AVR, you have depression. So how do we tell the difference when we have all of those findings? So we'll go back to our patient here. So you can see here you have ST segment elevations, they're concave, really no major reciprocal changes. You have your ST depressions in AVR, you don't have anything more than 5 millimeters. This is a patient that comes in with pleuritic chest pain, young, this could be pericarditis. So we're going to look at lead V6. In lead V6, we're going to compare the height of the ST to T wave. In early repo, the ST segment comprises a smaller portion of the height of the T wave. Don't concentrate so much on remembering the numbers. Just remember that in pericarditis, ST is the problem, right? ST is the problem. In early repo, ST is really not the problem. So ST comprises a smaller portion of the T wave. In pericarditis, ST comprises a big portion of the T wave. So the way you go is by 25%. So in pericarditis, ST to T wave ratio is more than 25%, 0.25. In early repo, the ST to T ratio is less than 0.25. So going back to our EKG, ST to T wave ratio, does the ST segment comprise most of the T wave height? And the answer is yes. It's definitely more than 25%. So this is classic EKG for pericarditis. It is not unusual for us to get transferred patients that have patients with chest pain and they get their EKG and they find ST segment elevation, they get diagnosed with pericarditis and they get transferred to us or we see them. And a lot of times actually ends up not to be because nobody looked at the V6 and this whole V6 phenomenon. So it's very important for you, whenever you're considering someone with pericarditis, look at the V6, figure out ST to T ratio, if the ST segment comprises a big portion of the T wave, then you're dealing with pericarditis. Otherwise, you're most likely dealing with just the normal early repo phenomenon. Now, in stage 2 of pericarditis, you have 3 stages. So first stage is acute pericarditis. Stage 2 and 3 is considered to be basically your chronic pericarditis. In stage 2, what you'll see is that the height of the ST segment diminishes. So whatever height it was, it diminishes, and basically PR has normalized. And the T wave, basically in stage 3, becomes inverted. So in stage 2, what you're getting is that the height of the ST segment, wherever you were, actually comes down, and the height of the T wave comes down. In stage 3, T wave inverts, and stage 4, everything backs to normal. It's important rule to know is that in patients with stage 3 pericarditis, the T wave inverts only after ST has come to baseline. You should not have T wave inversion when the ST is up. You should not have T wave inversion when ST is up. That is not stage 3 pericarditis. In stage 3 pericarditis, the T wave inverts only after ST has come to baseline. That's very, very important because sometimes people will have an acute MI. They go to another hospital, they go somewhere, and they were diagnosed with non-specific chest pain and musculoskeletal chest pain, let's just say. They come back to you. Now they have their chest pain, their MI has been completed, and their MI has gone through the evolution. Now it's in the stage where T wave starts inverting. But with MI, T waves start inverting when the STs are up. So it is important for you to understand this distinction, because this is something you will 100% see in your clinical practice, without a doubt. So let's look at this patient. This is a patient that exactly that's what happened to. 58-year-old male with chest pain for 1 day. What is going on in lead V4? ST is up and T wave is inverted. Is that MI or is that pericarditis? That's subacute MI. This is not pericarditis. If you look at this EKG, there's diffuse ST segment elevation, concern for pericarditis. Chest pain has been going on. Initially thought that basically pericarditis is going through its stages, although typically it's not this fast. But that's what the initial thought was. But a basic rule was misunderstood. In patients with pericarditis, stage 3, T wave inverts only after ST segment has come to baseline. If your ST segment is up and T wave is inverted, that's a subacute MI. That means MI has happened. We're going through its process of T wave inversion. So I want you to remember this. While your ST is up and T wave is inverting, it's not stage 3 pericarditis. So if they had a diagnosis of pericarditis, I don't care. That's not correct. We're dealing with a subacute MI. It was most likely an MI. Now we're going through its phase changes. And the last topic I want to talk about quickly, because certainly it comes, we do this all the time and we think about it, is pulmonary embolism. This is a 45-year-old male with shortness of breath. Obviously, we do not get EKGs to diagnose pulmonary embolism. We get EKGs to make sure nothing else is going on that is potentially manifesting as a chest pain and shortness of breath. However, there are some manifestations on EKG that can clue you in on if you're dealing with PE or not. And there's lots of EKG changes. I think there's more than 20 EKG changes have been described to pulmonary embolism, and obviously none of them are very specific. At the end of the day, all that matters is, as far as EKG changes, how big the clot is. It's logical, if it's a small clot, it's not causing major problems, you're not going to have major cardiac rhythm abnormalities or cardiac changes. If it's a huge clot, it's causing major obstruction, then we expect to see some cardiac changes. So it all depends on the burden of the clot. So when we talk about studies, what did the studies show? What is the most common? When somebody asks what's the most common finding with PE, well, your next question should always be, well, what is the clot size? Because it just depends on the clot size. Typically, with small clots, you're not going to see anything. With large clots, what you'll see typically is either sinus tachycardia, but some patients may not even have sinus tachycardia. But some clues that you should kind of be aware of is anterior T-wave inversions. Anterior T-wave inversions are a common finding with pulmonary embolism, at least large pulmonary embolism, to a point that it causes some cardiac EKG changes. So anterior T-wave inversion. So the reason I'm talking about this is because we look at anterior T-wave inversions in V1, V2, V3. The first thing that comes to your mind is, what does it come to your mind? The first thing, you say ischemia, right? I hope that's what comes to your mind. It's ischemia. The first thing that you think about is ischemia. But I want to teach you today one other thing to think about. I want you to think about PE. Anterior T-wave inversions, obviously in the right clinical setting, should make you think about ischemia, but also pulmonary embolism. Again, doesn't mean 100% that's what you're going to have, but I want you to think about that. I want you to consider that. If certainly there is more that goes to the story, that's important to follow up. The other thing that you'll see typically described is this whole phenomenon of S1, Q3, T3. So S wave in lead 1, Q wave in lead 3, and T wave inversion in lead 3. So S wave in lead 1, Q wave in lead 3, and T wave inversion in lead 3. This is nothing specific. It is not pathognomonic for pulmonary embolism, but certainly in the right setting, it still could be a point. It can point towards a right heart strain, basically pulmonary embolism. So certainly something to think about. So with pulmonary embolism, what are some clues? Like I said, there's many EKG changes that have been described. The one that I really want you to think about, remember, and keep it to memory is anterior T-wave inversion, V1, V2, V3 T-wave inversions. When you see that, kind of have it in the back of your mind, are we dealing with PE? Certainly S1, Q3, T3 in the correct setting. It's not pathognomonic. Just because you see it doesn't mean there's going to be one. And this is a good example of one. This is a 25-year-old male that came in with arm pain. And there was a concern for PE in this patient because of this. And this is absolutely no indication that this guy has PE. Clinically, this patient did not have PE. This EKG is actually a fairly normal finding on many patients. You're going to find this on many patients that have absolutely there's no concern for PEs. So that's not so unusual. So we talked about all of these things, and we talked about the EKG ones, EKG findings, and some take-home points. So for pericarditis, what you're going to find is diffuse ST elevations with an exception of depression in AVR. We're going to look at lead V6. We're going to compare the height of the ST to T wave. If the ST comprises a big portion of the T wave, you're dealing with pericarditis. You remember the clinical history is very important. Remember the pain should be going to the trapezius area. That's a very important aspect of the history of these patients. Remember stage 3 of pericarditis, you have your T wave inversion only when the ST has come to baseline. If your ST is up and your T wave has inverted, that's more a subacute MI, where MI is going through its process. And when should we think about PE? Certainly, it's not, EKGs are not diagnostic, but can give you some clues. The most important clue that I want you to remember is anterior T-wave inversion, V1, V2, V3. So think about that. Also, your S1, Q3, T3, obviously in the right clinical setting, but be aware you can see S1, Q3, T3 in many patients who absolutely we have no concern for PE. And I think that's my last lecture, and thank you so much, guys. It's been a pleasure. Thank you.